he came amongst. So, so he would have seen a lot of instances doing it alone in those days, and now with many of us joining, and he would have had a lot of successful instances and also situations where he would have burnt his fingers. So his presence going through this case, I thought would be a great opportunity to get his comments on this dilemma. And Professor Anil Agarwal, he is from US, and he's actually all the faculty today are very familiar to us. And he was the president of. He has had all the posts both in ASDIN and ISN as far as interventional nephrology is concerned, and he has many books published also. And actually, he is one of the people who is encouraging Indian nephrologists to take up interventional nephrology. And so, seeing us grow, he has been really gladdened. So, I wanted to show off these cases, plus get his opinion, his perspective from the other side of the world. So, with these two eminent interventional nephrologists amongst us, we'll have this session. Dr. Venkatesh Rajkumar presenting the cath lab salvage, and Dr. Sachin Soni presenting the operation theater aspect of salvaging AV fistulas. Now, both of them being here, and I think we can go on to the cases, and I need not spend more time in introducing the speakers. They have been prolific presenters of cases in our forum from the beginning, Rajkumar and Sachin Soni. And who would start now? Who is sharing the slides first?
You can tell me, sir.
Okay, you start from cath lab.
I'll start, sir.
Yes.
Right, sir. Sharing my screen. Good evening, all, and thanks, Dr. Bala, sir, for the opportunity once again. So the theme for today's informant is how far is too far. How far we should, or we may go to salvage and access. I know it's pretty much a generalized question, and the question is too generalized, and the answers can vary depending on a lot of things, right, from the patient factors. So the answer depends on a lot of factors, from patient factors, availability of expertise, the financial part, patient commitment, and a lot of other things. The answer could be straightforward and simple, like to create another access, or switching to a completely different modality in the form of PD, or doing a transplant a little faster, or you go all the way to try to salvage an access. Here is one such scenario wherein we thought we've done everything under our might to salvage an access, because we thought it was needed for that particular patient. And over the last 1.5 years or so, again, I understand there could be a lot of difference in opinion as to how this case could have been managed, or no, I'm sure a lot of us would like to manage in a different way. In fact, the whole idea of presenting the case today is to for that only, and to have a healthy discussion. With that introduction, I'll go into the case. So our patient is a 55-year-old female patient, diabetic nephropathy, end-stage renal disease, and initiated on dialysis through a right IJ catheters at another hospital. In a week's time, the flows were bad, and subsequently, the left side had to be canalized, and again, no flows on the left side, and she was referred to us. The catheter was removed by the time she presented to us. And she presented to us with a feature suggestive of central vein symptom in the form of arm and face swelling, which was relatively acute. Yeah. So we did a contrast CT venogram of the chest to see what is happening. You can see the system on both the sides, the right brachiocephalic as well as the left brachiocephalic. Both of them are stenosed, and you can see it's both inflamed, as well as you can see a good amount of contrast. Good amount of thrombus in there. You can see clearly here. You can see the right as well as the left brachiocephalic vein. They're inflamed as well as thrombosed. And the jugular access was not considered that time in view of an acute thrombus, and we thought the volume was also a little bit. So we thought like we will not access the jugular system. So consequently, we did a femoral TCC to save the day. And we started the patient on anticoagulation with warfarin for the central vein thrombus. You can see I think it's a 33 centimeter glide path we had inserted. And she presented to us in 2 weeks with, she was symptomatically better in the sense the swelling is gone, but the femoral TCC was not greatly functional, and there was some doubt of infection as well. So the TCC was removed and an upper limb access was attempted. Yeah, she presented to us 2 weeks time with symptoms suggestive of poor flows and potential infection in the femoral catheter. Consequently, it was removed. And we thought of putting it again, but the patient was insistent that she wanted an upper limb access. So we had to access the jugular system. So this is the right side. You can see the micropuncture needle and wire. We could not negotiate it, but we did not try much. We accessed the left side. You can see the left side has canalized very well, almost to normalcy, I would say. So we went ahead and put a 23 centimeter glide path on the left side. And subsequently, left brachiocephalic fistula was created. We saw her, and after another 3 months, the fistula was immature. Ultrasound revealed a long segment outflow stenosis along with a little bit of thrombus. Sorry, I could not have the ultrasound pictures here. And she was consequently planned for a venogram and proceed as far as the maturity of the access is concerned. You can see the access here. It's a brachiocephalic fistula on the left side. The juxta-anastomotic area looks all right. There is a collateral there, but more than that, the flow is not very great in the outflow. There is a long segment stenosis along with a thrombosed, semi-thrombosed outflow. We used a long, I think we used a 4 into 100 millimeter Mustang balloon. So that is the area of significant stenosis, and it opened up pretty easily. You can see the post-plasty flows, which were good. We were about to wind up the procedure when we noticed the flows and thrill was gradually reducing. You can see there was a pre-procedure venogram showing an outflow thrombosis, I would say. Post-plasty, the flow was okay. But in another 5 or 10 minutes, the AVF thrill reduced as well as the flow was reducing. And ultrasound revealed a hematoma in the mid part of the arm, which was compressing the AVF. It was not an expanding hematoma, but what we saw is the hematoma, the volume was, there was no much space for the hematoma to expand there. So it was compressing on the fistula, and consequently, the fistula was almost about to get thrombosed. Again, I do not have the ultrasound pictures with me now. And if we observe carefully, this we missed it during the initial angiogram, there was a leak there. So there was a small rupture, and consequently there was a leak giving rise to the hematoma. You can see the leak there in the mid part of the arm. And we decided to use a stent. Cook Silver retinol stent is the only stent which was available to us on that day. We used a 6 mm into 10 centimeter Cook Silver stent. You can see the stent getting deployed as a way to prevent the hematoma from compressing the fistula. And you can see the post-stenting flows. It was good. The flow was re-established. The flows in the central vein system, it was again good. There is a good amount of thrombus all along the cephalic vein, cephalic arch, also into the proximal part of the subclavian vein, but we did not do much because the flow was maintained. We thought it should get washed away naturally. So we did a bit of post-dilatation as well. And the flows after post-dilatation, they were good. But there is a bit of thrombus along the distal part of the cephalic vein, including cephalic arch, as well as the proximal subclavian vein. But we did not do anything as the flow was good. And we started the patient on warfarin. We did a periodic ultrasound follow-up to look for that hematoma or the pseudoaneurysm, just to make sure it is not increasing or it is not pushing against, or it is again causing compromise to the fistula flow. The aneurysm or the pseudoaneurysm was stable with some blood flow into it. There is a blood flow into it even after stenting, but it is stable. It is not increasing. It is not aneurysmal sag, but we did not do it for fear of AV fistula thrombosis, and the fistula was otherwise doing okay. In a month's time, she started developing features suggestive of central venous stenosis with face and left upper arm swelling. It's probably because we opened up an immature fistula and there was an already existent central vein stenosis. And we did a CT venogram again. You can see the left brachiocephalic vein is completely stenosed around the existent perm cath. So there is a 2.5 centimeter long severe narrowing of mid left brachiocephalic vein with the residual lumen obliterated by the central venous catheter. That will explain the symptoms. The flow inside the stent, you can see the stent has resulted in maturity of the fistula. The flow is very good. Only thing is the aneurysm or the pseudoaneurysm stack is still there with a bit of blood flow into it. Only thing is it has been stable. We have been observing with ultrasound every now and then. There is a bit of cephalic arch stenosis as well. And you can see the flow inside the central veins. So there is no flow beyond the mid left brachiocephalic vein. This is a venogram after removing the permanent catheter. You can see there is no flame. The flow is very poor beyond the mid brachiocephalic vein. So we started, so that's a cephalic vein with a aneurysm, pseudoaneurysm there with the blood flow into the pseudoaneurysm despite the presence. I have to remind you that there is a bare metal stent. We have not used a covered stent. One, it was not available on that day, and number two, it was expensive, and number three, we thought like this should serve the purpose. Cephalic arch stenosis as well as central vein stenosis. So what we did is we started with a 6 mm balloon. We went ahead all the way up to 12 or 14, 6, 8, and serial dilatation we did. I think we went up till 12 mm Mustang balloons. And this is the flow after 12 mm angioplasty. The flow is definitely better. It is re-established, but there is a significant recoil. You can see, I'm sure like all of us will agree, this is not the result we would like to have. So we wanted to put a stent as for this recoil. This is a marker pigtail to help us understand the length of the stent we might need. We used a 14 into 100 millimeter Medtronic Abre stent. You can see the stent getting deployed there. And that is the flow after stenting. The flow is definitely better. So we did a bit of post-dilatation with 12 mm balloons. And this is the final flow, which is good. You can see the flows. It's definitely much better than before. And the cephalic arch, we did not touch for two reasons. Number one, she did not have any symptoms pertinent to the cephalic arch stenosis. And number two, we thought like opening it up unnecessarily might worsen the central venous situation. We thought we'll intervene if at all necessary. But again, as you might well imagine, she presented again in 6 months, this time with a prolonged bleeding time and a high venous pressures, which we thought probably was due to worsening cephalic arch stenosis, and it was right. You can see the flow inside the stent now. The aneurysms, the pseudoaneurysm stack is completely thrombosed. Again, I'm sorry I could not give you the ultrasound pictures, but there is no flow into the pseudoaneurysm, which was there in the venogram done 6 months back. The flow is nice through the stent. And we have been using this fistula by then. And you can see the flow through the central veins. The cephalic arch stenosis has definitely worsened, but the flow through the central venous system is as good as it was 6 months back. And the stent was well in position. So that was the cephalic arch stenosis angiogram done 6 months back. This now the situation of the cephalic arch now, which is definitely worsened, contributing to the prolonged bleeding time and high venous pressures. And we did a 8 mm angioplasty with a Mustang balloon. And this is the final picture. You can see it is much better than before. Sorry. So that's the final picture, which is we left it there. But she presented again to us in 4 weeks' time with a prolonged bleeding time. This time again the angiogram livid. You can see the flow through the fistula, which is very, very slow with a lot of reflex backwards as well. The fistula, I would say, it was about to thrombose by the time we did the angiogram. You can see the flow through the arch. There is no much flow beyond the cephalic arch. It was stopping. It was about to get thrombosed. So we used whatever balloon was available that time. And we used a 6 mm into 100 millimeter Mustang balloon. We opened up the lesion and the flow was immediately re-established. But the flow has recurred the problem has recurred in a matter of 4 weeks. It was almost about to get thrombosed. We thought like it's a recurrent cephalic arch stenosis, which has recurred in a period of 4 weeks. We thought that merited a stenting, and we used as usual, used a 8 into 60 millimeter Covira stenting here. You can see the stent getting deployed. And there's the angiogram post stenting. We did a bit of post dilatation. That's the final angiogram. So the flow through the fistula and flow through the fistula as well as the flow through the cephalic arch and the central veins. This is the latest angiogram we did maybe week back. And there is a present status of the access. Did the CNE to show you the access. The patient has got a Met Habre 14 into 100 millimeter stent in the central venous system and Povera covered stent in the cephalic arch and Cook-Zilver internal stent in the venous outflow. So that is the present situation. At least to my credit, I can say the fistula is functional. I am using the fistula. So this is the timeline. Everything started on last September. We put a femoral TCC with anticoagulation for bilateral brachiocephalic vein thrombus. She came back to us 2 weeks later. The femoral TCC was removed due to infection and poor flows, and we had to put a left internal jugular tunnel catheter as she insisted on a upper limb access. And after 3 months, we created a brachiocephalic fistula on the left side. And after another 3 months, it was immature. We did an angioplasty. There was a rupture, compression with a hematoma, and we had to put a cephalic venous outflow stenting. And in the next month, in a month's time, the patient presented again with a central venous symptom. This time we had to do an angioplasty and stenting for the left brachiocephalic vein with an Abre stent. And after 5 months, that is the longest time she had given us. She presented with a prolonged bleeding time. This time due to cephalic arch stenosis, we did an angioplasty alone. She presented to us in 4 weeks' time with a recurrence of symptoms. The fistula was almost about to get thrombosed. We had to do an angioplasty, and this time we did a stent grafting for the cephalic arch stenosis. Yeah, so last 1 or 2 slides before we go into the discussion. So what could have been done differently? In retrospect, just thinking, maybe we could have done a preemptive AVF. To be honest, I did not have that time, and she presented to us well with a lot of symptoms, so we had to put a catheter for dialysis. And maybe we should have started, she was not, the initial few lines were not placed in our center. Maybe we would have planned for a guided TCC placement to begin with. We had put a proper right-sided TCC with the tip in the mid-RA. Maybe that could not have been a need for a left-sided access, and maybe the left-side system would have remained pristine. Maybe we should have exhausted the right side before proceeding on to the left side. And maybe an AV fistula and AV graft on the left side, we should have considered without a tunnel catheter once the system has recanalized with warfarin. But the patient was very insistent that she wanted an upper arm access, so we had to put a left-sided catheter. Otherwise, a femoral TCC with a brachiocephalic fistula on the left side, that would have been done. And we have never attempted a right-sided brachiocephalic vein recanalization. And if successful and a left TCC was avoided, maybe the left brachiocephalic vein would have been spared, and maybe we could have gone for a lower limb vascular access, leaving all the upper limb central veins or the upper limb stenting aside. So these are the things which could have been done differently. I'm sure there's a lot of difference of opinion as to how somebody else would have managed the patient or would have wanted to manage it. So we'll be open for that discussion. So these are the stents we used here. For the outflow, we used a Cook-Zilver 6 into 80. For the central veins, we used a 14 into 100 millimeter Hambre, and for the cephalic arch, we used a covered stent, Povera stent grafting. So I'll stop there, and maybe we should maybe go for the discussion part, sir.
Thank you, Venki.
Yes,
I think you were smart. Like you gave all the alternate steps which could have been taken, which might be suggested by the audience by yourself. Thank you. I think we'll have discussion now itself so that things are current in everybody's mind. So
Yes.
let me start with the comments from the seniors, chairpersons. Professor Raja Purkar, sir.
Well, I think it has been well managed is what I would say to begin with. And all the other options that he mentioned could have been used, no doubt. But if you're stuck with something at that point of time, you have to go as far as possible, not only. So one thing is that if you're going to do this on a more regular basis, the cath lab should have all these instruments available all the time, though they're rarely needed. But when you're doing central vein stenosis, it almost always should have things ready and also a surgical standby ready, which is what was my practice. I've never used a covered stent graft. We thought whether it will reduce restenosis, but I think unless I have, and in the last 3-4 years, I have not been up to date on the, I have not anymore doing. So I think what he did was right, except that I would have seriously considered a left femoral fistula with exteriorization of this saphenous vein. So you get a long segment. So I make a fistula into the adductor canal with the femoral artery and exteriorize the saphenous vein. And then let everything else settle down, remove all the central things, and see how things go. Uh, a much better explanation about how to prevent infections in tunneled catheters, because infection and thrombosis go quite hand in hand. So that would be my initial comments.
Sir, when you say you never had to use covered stent, is it that you were lucky or you had other methods to
I
get
was lucky.
from the complications?
I was lucky.
Right, sir. Yes, Professor Anil.
Good morning for me, and good evening for all of you. So first of all, before I even comment about the case, I would like to just say how privileged I am and how pleased I am to see this big gathering of interventional nephrologists from India. It's like a dream come true. We talked about it several. Somebody's mic open. So it was about 15 years ago in Lucknow that we were all thinking about how to start interventional nephrology in India, and you all have made that dream possible. So thank you very much, and kudos to all of you. And being this right after the day of Thanksgiving, I'm very grateful to all of you. And thank you very much for taking care of people in India. So about this case, one thing that obviously Professor Rajapurkar already talked about and was very well presented. Thank you, and was very well managed, Dr. Venki. So I mean, no question about that. I think the theme is what could we do in a resource limited country, as we talk about. I mean, and everybody's resource limited, even in US. I mean, it's not like there is an infinite amount of money to spend on these things, but is why did we even start this young patient with catheters? So that is the first thing. So the whole presentation we did, we were fixing what we caused with catheters. So I think my first thing would be, can we improve the pre-dialysis care? Do better, do vein mapping, create good AV fistula, so we don't even have to use the catheter and not having to deal with all these issues. Now, as you saw, within a span of about a year and a half, there were at least 7 or 8 different procedures that we did on this patient, and it's okay. I mean, there are some people in India who can afford it, but the majority, as you know, cannot afford it. And it comes with the risks of using the anticoagulation, different procedures. When you are intervening in central vein, the patient can die. All those things can happen. Of course, we try to avoid all those problems. So work-wise, excellent work. You saved the fistula with a stent in the arm, then you save the central veins with another stent, and then you brought back the fistula with the cephalic arch stent. So it is working only until it is working. I don't know what your patient is doing right now. So, and could be coming back to you. I hope not, but could be coming back. More than likely will come back very soon. So I think it is important to start even now, even at this point, I would say you should start thinking about maybe another access, perhaps not in upper extremity, because the central vein is not going to last forever. and the patient is still relatively young. So maybe start thinking about another an AV access in lower extremity, that if possible. So we should always pre-plan for the next thing that is going to happen, and we know it will happen. So sooner or later, we hope it is not soon. So those are basically the main things. I would say let's stop using catheters as much as we are using. It is in India that I've seen people with a temporary catheter for a year, even the non-tunneled catheter. So let's try to improve on that part, teach people in general practice and then in nephrology to start using, planning for dialysis sooner. So that's what my thoughts are in a nutshell. But excellent work done. So congratulations to all of you. But then this is something probably avoidable to quite an extent. Thank you.
Thank you, sir. And from the audience, anyone wants to chip in now itself?
I see Adrian there too. So Adrian, you want to say something?
Yes, I completely agree. First of all, good evening, everyone. And Dr. Agarwal, nice to see you after Thanksgiving. That was a surprise. Yes. I heard you were there, so I came. First of all, Venki, we see this every time, and you did everything correct. So kudos that you did your best to salvage the access. In some patients, it is going to be an expensive affair. The only thing probably, I wanted to talk about two things. First thing is something similar happened to me just last week. Patient has an upper arm AV graft. So I was thinking in your case, could we have put a early use graft if it is possible? That way we could have taken out the catheter from the left side because, left side causes more stenosis. That way, even if the access goes down, you can create a fistula. So therefore, you're extending the life of that arm. So that's the only thing I would have done different. In my case that I had last week, patient has a brachiax graft on the left side. Patient has a catheter on the left side and has come with face and arm swelling. So now I'm in trouble because they stuck the fistula graft only once. And they said it ran beautifully, but the whole arm is swollen. Fix it. So as you would expect, I did a fistula graft and the brachiocephalic left is stenosed around the catheter. So what do I do now? Right? So I put in a balloon. And so I was wondering in your axis, when did the catheter come out? I guess when you were stenting, you pulled out the catheter, is my guess. But in this lady, we have a catheter in, and I have to angioplasty. And so I was alarmed when you said 12 millimeter balloon. Then I realized the catheter is not in. So in my case, I have a catheter in and I had to angioplasty. So the catheter is about 5 millimeters. So I used a 7 millimeter balloon. That means it has expanded to 12 millimeters. That's what I did. And within a week, I called the patient back, which was just last Friday. And I pulled out the catheter and angioplasty the vein again. And that was it, send the patient home. So nothing different what I would have done. Congratulations to you. It can be expensive. But as Dr. Agarwal said, what can we do to avoid those catheters? And like him, I feel the same thing. I hate it now. I hate it. And I hate it when I have to pull that catheter out and patient is in so much pain and discomfort. And there's a scar on top of that, especially if it's a woman, she has a scar on her chest. And the best thing they always tell me is, Doc, I can go take a bath now. I said, yes, you can go take a bath now. So you did everything right. The only thing would be, could we have put an early stick graft on that side so you can pull out your catheter?
Yes, sir.
And then the other thing interesting was this tunnel dialysis catheter in the groin. So I used to be like you. I used to do 32, 42. Now I just put the tip straight into the right atrium because that's what we do when we put the catheter in the IJ. It goes in the atrium, doesn't sit in the SVC. But now I put a long catheter straight into the right atrium when I'm going from the groin as well. So that will usually be a 50 centimeter catheter. That's it. That's all I want to say.
One quick question are the early grafts available in India? I don't think so.
No, sir. I don't think we have early cannulation.
It is available, Krish.
It is, sir. Which one, sir?
I remember.
But they can use
using it.
Gore graft or BD graft, sir?
I think it's Gore. I remember I not using that, but I think it is available. I'm not very sure.
Okay.
I think my vascular surgeon has used it. Krish. I think it is available.
But they can also use a PTFE. In 2 weeks, that catheter would have been out.
Yeah, that can
You
be
know.
very. That is one
Either
thing
way,
which I
either
had
way.
also discussed. Yeah, but she was very insistent on getting an upper arm access that time. She did not want a femoral access again. So the only upper arm access that time was a left-sided. Left-sided intrajugular was the only vein
No,
which was.
I was talking about a left upper arm graft, not in the groin. I was not even talking about the groin.
Yes, left upper arm graft, but for the meantime, for 2 weeks, 3 weeks, the femoral was not functioning and she was not very keen on getting another femoral line.
Venky sir, how about her axillary vein? So in case this stent gets jailed, can we do a brachioaxillary graft or a transposed brachiobasilic?
Yeah, Girish, Professor Rajapurkar has raised his hand. So let him finish his comment. We'll come back to the discussion.
Yeah.
Yes, sir.
See, basically, I agree about not using catheter, but what happens often is a patient is counseled when the GFR is about below 20 to undergo dialysis. He promptly changes the doctor and goes somewhere else. That is what most youngsters have told me. Though we used to always tell our people, even then patients wait till the last minute, that when it becomes, they come with pulmonary edema and then you have to dialyze them. So catheters we don't like, and we should make every possible effort to try and preserve veins of everybody when they are not in renal failure as well, because they might have, these diabetics tend to have other vascular diseases at which time they have had multiple central vein cannulations for say if they were undergoing a CABG or some such thing. So we can't just do away with catheters, and this needs to be discussed on every round. When you're doing rounds in your nephrology wards, everyone should make sure that the veins are preserved as much as possible for everything, because too quickly people put central vein for just monitoring the CVP when patients are not really bad also. So that point is definitely there. And I think the cost saving for grafts, I found that the saphenous vein grafts can be cost effective and can be used. Now, about the brachiobasilic transposition for this particular patient, that you can do, but you're still faced with the central venous stenosis, which can come back again and again. And therefore, you'll have to keep on intervening there later on also. With the stents there, ensure that you're within the system when you're putting in the wire next time. That's true. So I would say if they had to do a fistula, preserve the left side first, get the catheter into the right, which had been completely blocked maybe, and then do a brachiobasilic to begin with on the left side. If the left brachiocephalic had opened up with your conservative treatment, would have been considered. I have at least in 4 or 5 instances used the saphenous vein exteriorization near the adductor canal. The saphenous vein is very easy to get there, and the femoral artery is also quite superficial. So you make a fistula there after exteriorizing the saphenous vein, and then you get a long straight thing on the thigh. It's quite stable.
Where do you do the anastomosis there, sir? Like
in the adductor canal. Down below. Upper 2/3, lower 1/3 in the thigh.
Yes, sir.
Right. Before we go on to the next case, Venki, can you quickly reshare your slides and describe the hardware you use so that the names were very unfamiliar to most of the audience? So just 2 minutes. The various stents, the names.
So only the stent part I have kept, sir. These are the stents we used here. So we used a bare metal stent. The Cook Silver is an internal stent. I think it's a closed cell design. for the outflow rupture, use a 6 mm into 80 mm Cook silver. I generally, there are 2-3 options available in our country, but this is the only stent which was available that day. And for the central veins, again, you can choose between covered stent grafts or a bare metal stents. I think in our country, the only stent graft which is available is Fluency Plus. I don't think we have anything else at this point of time. And bare metal stents, again, you have a lot of options. Of late, this is something which we are using more and more in our center. If at all we want to use a stent, because I think it's got an open cell design and it is very easy to deploy. And more than that, it exactly the precision is very good with this. It doesn't overshoot. It remains the same as you can see in the angiogram. 6 months or 8 months down the lane, it's exactly where we wanted it to be. And it conforms to the curvatures of the veins pretty beautifully. So it's one of the venous stents available. The other venous stents being Venovo from Bard and have Optimed and other 2-3 things. But this is something which we commonly use. As far as the covered stent grafts of this diameter, between say 8 or 9 millimeters concerned, because one indication for a covered stent is graft to an anastomotic stenosis. Other common indication being the cephalic arch stenosis, which needs a stent. So I think this is the other option is Fluency Plus, but again, Covira confirms to the curvatures of the vein pretty beautifully in our experience. So this is something which we normally use.
Venki,
Yes. Yes, sir.
the choice for stents to be used, to extend between the left brachiocephalic into the SVC, to take
Yes,
that
sir.
right angle turn, you have
Yes,
any
sir.
reason to choose one over the other?
Yes, sir. I think it is based on, to start with, I'm sure Dr. Anil sir is here, he'll be giving his comments. But when we started, we used this wall stent. It's a stainless steel stent because it was very cheap and I have not used much other stent that time. There's some 8-9 years back. But what we saw is invariably the instant restenosis happened. It was very stiff. It did not conform to the curvatures of the central veins. Then we started using this other nitinol stents like the Epic and Illuminets. They were okay. That's definitely much better than wall stents, at least in our experience. But again, we thought like it did not conform to the curvatures of the vein, and we saw a good amount of instant restenosis. Then we switched over to this Fluency Plus covered stent, which in our experience was definitely much better than the other stents. But of late, over the last 1.5-2 years, we have been using this dedicated venous stents. We've got 2 or 3 options. All have this open cell design, which makes them conform to the curvatures of the vein in a very nice way. Because they commonly used in the iliofemoral situation where there is the veins are pretty much straight. But here in our situation, the central venous situations of the chest, the veins, particularly the left brachiocephalic vein, it takes almost a 90-degree bend. And if you have a stent which conforms to that curvature, it is good. And this is something, the Abre is something which has done that job very well for me. I'll be open to Dr. Anil sir for his thoughts and comments.
1 minute. The covered stent, the Fluency you mentioned, but
Yes,
putting it to take the curve, jetting
yes,
into the SVC, would it block the flow from?
So the SVC, it's almost 18-20 millimeter in diameter. The maximum size which is available in a country is 13.5 only. That's the one which I have used. Most of the time, it doesn't cause that, sir. I have not faced that situation so far. Having said that, I avoid getting the covered stent into the SVC. But I have done that in a few occasions as well without much of a trouble.
Okay. Right then.